when we're thinking about moral injury, when it comes to healthcare professionals and dental professionals, it's like, because we are up against insurance. And a lot of times the dental professionals in particular, I know, and now more and more medical professionals say, I just can't accept insurance. You'll see it a lot with behavioral health specialists as well, because the reimbursement is so low and the hurdles are so high that it's just creating more obstacles, and it's not creating the benefit that it claims it is for the patient. Well, thank you, Dr. Thoppay, for joining me again to crush the myths and help people understand the difference between medical insurance and dental insurance.
Well, I think here in US, with the US healthcare ecosystem, we definitely have two distinct coverages. And of course, there's vision, but we can like not focus on that in this video. Focus on the medical insurances and the dental insurances. So when we talk about medical insurances and oral medicine, a lot of oral medicine providers use medical billing. Believe it or not, they are medical conditions reflecting in the mouth. And if it happens to be a medical necessity, it is covered under medical insurances. And conditions like oral lesions, jaw pain issues, or jaw conditions, they are potential conditions that's not affecting the teeth, that's not affecting the gums. However, it's the orofacial area or oral and maxillofacial area that can be covered under medical. And on the dental aspect, so of course, dental insurances, they are a little different. And for someone who, my patients always ask like, oh, what's the difference? Some patients are very savvy with what their benefits are, but not everybody has that information. It kind of depends on the coverages, same as like the, medical as well as the dental. So there's few things that you really, really want to know about are the medical insurance HMOs, medical insurance PPOs, same thing to do with the dental HMOs and dental PPOs. So PPOs gives you some privilege to choose your provider without a referral. So if you have an HMO, you need a referral, especially to even see an oral medicine specialist for jaw pain to get covered under the medical. You definitely need that coverage and referral for HMO patients. However, for the PPO plans, you can actually go and see a oral medicine provider and use your medical insurances. And most of the oral medicine providers, they practice in the hospital system or affiliated with the hospital system, or they even be as a faculty dental practitioners or under the residency programs. So I know you mentioned a little bit about the military and
because I actually in dental school, I was so disheartened when I would present this treatment plan and the patient's like, I can't afford it. And it was causing to moral injury with lack, I was like wanting to provide as much treatment as possible that the patient needed. And so I was constantly up against, well, the affordability, and we know that dentistry is not cheap. And the insurance aspect was that something I just didn't want to have to figure out or navigate. I didn't want my treatment plan to be squashed by insurance. Still to this day, when it comes to seeing patients I was a patient when I was a resident for oral surgery. I was severely ill. It was to a point where my doctor said, if you don't get an intervention, you could die. And so they referred me to this hospital in Colorado. And I called them. I was active duty military. So we're talking, I fit the criteria for medical admission to their hospital. And they asked me, what's your insurance? And I said, TRICARE, which is a military insurance. And they said, we can't accept you. And I said, well, what if I had the best primary insurance possible? And they said, nope. And I said, well, what if I paid out of pocket, which I knew I couldn't? And they said, nope, we can't accept you. So it put into perspective what a lot of patients faced was like, I'm having sometimes life-saving treatment, or when it comes to dentistry, maybe it's not, but they're in severe pain. And they're like, well, I can't get a filling to save this tooth, even though the dentist said it was restorable and I have to get it extracted. And then you have functional deficit from having to choose between those two. but it created, as you can tell, this like profound fuming inside of myself because we see it day in and day out. And when we're thinking about moral injury when it comes to healthcare professionals and dental professionals, it's like because we are up against insurance. And a lot of times, the dental professionals in particular, I know, and now more and more medical professionals say, I just can't accept insurance. You'll see it a lot with behavioral health specialists as well, because the reimbursement is so low and the hurdles are so high that it's just creating more obstacles and it's not creating the benefit that it claims it is for the patient.
So I think you brought up a good point of like you had TRICARE and why they wouldn't accept you. So there's another concept. What they have here is being in-network provider and out-of-network provider.
Yeah.
So say, for example, if I have to see a patient who has maybe like, Aetna. Aetna is very common here, or Florida Blue. Okay. So unless like I participate, agree on a contracted value, and then I kind of accept. So my fee could be somewhere, say, for example, $100. But as an in-network provider, maybe I have contracted with them for $75, and with Aetna, maybe $90. So as a provider or as a medical office or dental office, on the medical side, you have to be noting those numbers and then either like collect it if they have something called as deductible, which is until you meet the deductible and you're seeing a specialist, it's not a routine care, it's something of your medical necessity. But if you have a deductible that qualifies you, then we have to charge that. They will still pay it to the office as part of their deductible until they meet the deductible. Then their reimbursement will start coming in. So this is complex. And based on my personal insurance, I think I have an $8,000 deductible. Wow. Which means it's like every single outpatient, if I need to see outside of my routine, physical exam, there has to be a deductible, and whatever the deductible number, and then the fee that is contracted. If I see an in-network doctor, then it is like, they will put under the deductible. Say, for example, if I go see a specialist, I pay, if their fee is $100 and my insurance contracted for $90 and I have a deductible, until I meet the deductible, I pay the provider $90 every single time I go there, which technically means I'm paying it out of my pocket.
Yeah. It's like such a pain point for so many reasons, right? And to kind of recap parts of our conversation is if you're going to see an oral medicine clinician for a specific diagnosis workup, ask which insurance that would be under, because different conditions could be used under different insurances so that you can better understand what to expect. And also the awareness of why clinicians may not be able to accept the insurance because it wouldn't be sustainable. And a lot of times it can be like, oh, they're just trying to make a lot of money. And like, but they would just not be there. Their office would be shutting down.
Well, that's one of the most challenging situations, because there is something called as cost of practice, which is like if you have to keep your doors open and you have to have this much amount per hour that you should generate in order to keep just the doors open, not paying the doctor, not paying the the providers, or your front office, your team. But there is significant cost even for the electronic healthcare systems. There's significant cost in running all this, tests and all those, needs for and utilities and everything. Mm-hmm. But if your reimbursement rate is significantly lower on the medical side, it can hurt the practice, and that can make them be more, challenging for them to sustain the practice. And also sometimes, it might demand like the volume over, you have to keep up that volume to be able to make that basic numbers, even to keep up to open the practice. So the other factor is, even if it is a medical insurance, the medical insurance coverages differ based on the insurance levels. Say, for example, in oral medicine practice, if a patient comes with a dry mouth, the clinical evaluations can be covered because, the health physical exam and all those factors. However, if I have to do a salilometry test and analyze the saliva sample, it definitely incurs a cost, and we don't have coverage for the saliva testing. So, which technically means that it's an uncovered procedure. So, your medical insurance is not going to cover the procedure. However, it still is the standard of care, but for some reason, this oral medicine becomes a leeway between the medical and the dental. So, some of the practice standards are something that you're working up for oral medicine care. And you're trying to see if we can kind of generate that evidence base to see and seek the coverage. And a lot of times, when we look into the dental aspect, what could be covered and what cannot be covered. Say, for example, if you have a tooth problem and you have dental insurance, they go by codes and the procedures that they do. And some procedures, maybe this is something anyone who has dental insurance is very well aware of. I'm not talking about HMO. HMO coverages are a little different. It's by per visit, but the
Yeah.
PPO. And if you have a PPO plan under dental, it is like a cap fee. Unlike the deductible that we talk in medical, we have a cap fee, which is like cap amount, which is like, say, for example, if your insurance says we will cover up to $2,000 per year, and those $2,000 could be based on the procedures. Say, for example, I'm going to have 4 fillings, which comes under restorative codes, procedure codes. Okay, on the restorative codes, your insurance may say that they will cover about 50% of the charges. If you see an in-network provider, it could be 50%. If you see an out-of-network provider with a PPO plan, it is 25%. So now there is a catch on this. Say, for example, if you're seeing an in-network provider, they have contracted a fee. Remember, I mentioned in the very beginning, same as the medical provider, dental providers, they contract with their dental insurances. Say, for example, for the filling, okay, it's like $100 is the fee that the dentist contracted. However, the standard fee could be $150, but $100 they contracted. The patient pays $50 out of pocket and the insurance pays $50. If you see an out-of-network provider, they may still cover based on your PPO plan, but they will cover 25% of the 150, and your 80% will be that amount that balances out of that 150 will become your out-of-pocket. And that's why they say you prefer to see an in-network provider versus out-of-network provider. However, lot of oral medicine provider, as per my knowledge, they are predominantly under the medical. So if they are under the medical, you can also be under the dental, but again, you cannot like use those insurances in 2 different insurances. One common example that I can give is a panoramic x-ray. So you can take a panoramic x-ray under medical, little different governance there, where you have a deductible, you will pay all the money. Whereas if you use the dental, technically it will be covered once in 3 years. So you get like one free pass once in 3 years. So if you're going to use the dental, you can still do it.
Yeah.
But
I
it's
think
a little tricky.
it's so important. And sometimes when people were trying to explain dental insurance for me as a dentist who's just never taken insurance, it was as a patient, right? So I started off with an HMO and I was like, well, that's horrible. I switched to a PPO. It's horrible, not only for me, but for also the dentist. I was like, why did I do that? But it was a time where I was coming out of a period of not having any money. So I had this money scarcity. So I was like, I'm going to save money by doing this low plan because I had never needed a filling. Well, that times change, right? Yeah. Well, times change. I broke a lot off of my tooth off. So I had to get some fillings. And then is when I realized what you're saying. I'm like, I went to save money and I went for this lower paid plan, like you pay lower up front. But then I ended up paying about the same if I would have had the PPO. But the reason why is because I delayed the care I needed as a horrible dentist I am until I switched insurance and then I got the treatment. Because it put me in such a predicament for it was such an anxiety provoking time period because I was like, I'm hyper aware of what's going on in my mouth right now. And then I made a mistake because I was trying to cut costs. And that was, I understand why. It was a vulnerable time without making money at the time. But if people are thinking the same thing, I highly recommend doing your due diligence, getting that insurance that covers you, and also knowing that there's going to be dentists that don't accept insurance just because the insurance is not on anyone's side for the most part. And particularly when dentists are telling me it's more like a coupon and not really
True.
insurance.
I'm glad that you brought up the term coupon because say that, like I mentioned, that they cover $2,000, right? Say, for example, and not all the $2,000 you'll be able to utilize because one, um, if you have fillings that it needs to be done, okay, and remember only that certain portion is covered, and some insurances they even limit the cap of how many fillings you can have per year. And then you have the cleanings. And do you want to go for the deep cleaning? They will cover it once in 3 years or 2 years, depending on the insurance coverage. And then you may want to have more cleanings, but no, because they will cover the cleaning twice per year. And that too, they cover the basic cleaning. So a lot of my patients come and ask, oh, my cleanings are free with my insurance. And the key is that they don't cover the deep cleaning for free, but they cover the very basic prophy for free. So even for the cleanings, it can go into multiple levels of the based on the requirements. So a prophy cleaning is just like a superficial cleaning, and a little bit advanced cleaning, which is not like a deep cleaning, is just like, taking a little bit more extra, but they don't have something called as like the periodontal disease. They have gingival inflammation, like gingivitis, but not the periodontal disease. There's a significant difference to that. When you have the periodontal disease, you will definitely have to go for a deeper cleaning. The common term, okay, that's like a scientific term is the scaling and root planning.
Yeah,
And
I like deep cleaning. Sounds better.
yes,
Yeah.
yes, right, for the understanding purpose, which technically means you're going deep down to the pockets and debriding in and out. And also, there is necrotic bone that may not permit your healing process, which they are going to level it up so that you promote healing processes. So, all these various levels is not like something that's very obvious in your dental insurance. You have to look through, and when you look through the details, it will show a lot of numbers. What does those numbers mean? Well, they mean that they are the procedure codes, which is the CDT codes for the dental, and for the medical procedures, it's CPT codes, and then the evaluation codes. And then, like, you use like how much you can use in one visit for the medical, and how much you can go or how far you can go. What are the steps in dental? We are governed by such a regulation of how these codes can be utilized, so that, like, we are not like saying, for example, you can, now they're changing, you cannot do the debridement and the new patient exam both on the same visit. You cannot do deep cleaning, the full mouth, the same visit. You have to do one half and the other half. So it has to be two visits separated at least about a week apart, practically. That's something you have to overlook. And in the context of medical complexity, one of the common things that we came across, and that's like right now being evaluated, is can I do the debridement and complete the new patient exam the same time? Think about it. If you're having the same patient for oncology visit,
Yeah.
do we even have that much time for the
No.
patient to go for the radiation? No.
It really upsets me very, very much that our care is directed by insurance, because I hear a lot of the medical physicians and hearing the hoops that we have to consider do not make logistical sense for our patients, especially even if the patient wasn't in this truncated time frame that we had to get them done with their dental treatments before radiation in a very expedited manner. But just taking off work, or if you have a child, like managing getting to the clinic, we understand is a hurdle. And then you're going to force that person to come back, right? And if you think that you could have done everything in one visit.
True, very true. And there, after COVID, I think there are some significant thought process that went into these codes and how they are utilized, and having the televisits and the remote monitoring, all those things change to some degree, which is like beneficial because at least it's cutting down the cost of patient traveling from point A to point B. Even that is also cost for the patient, right? Apart from buying the insurance, apart from paying the doctor's office, travel costs. But then you have something else that kind of creeps up, which is the technology fee.
Yes, the technology fee, and it was hard for me to do televisits because a lot of times people came with oral lesions, and the palpation part is so important that I felt like it was an increased liability. So unless it was like an oral facial pain follow up or
Right.
something that wasn't, oh my gosh, do I have cancer or not? Then I was really judicious in what diagnoses and what patients that I felt could be appropriate for telehealth visits.
Exactly. I think that's very true. And on the other hand, for dentistry, how can you even practice on televisit, right? Maybe emergencies. Even then, like, you want to take the x-ray and see, and we have those kind of limitations in dentistry to have that like remote or televisit approaches.
Yep. Yep. So there are some circumstances where if it's a follow up, and I think sometimes right now we see at the institution I'm at, there's patients that are out of state, and we're like, well, depending on what state you have license, there's going to be hurt. Like, can you actually have that telehealth visit with that patient that lives in this state? You have to have a license in that state that they're now in before you can offer them that service.
Absolutely.
Well, thank
Absolutely.
you. This is one of my least favorite topics, but most important to talk
I
about.
think it's most difficult topic too. I mean, that's like apart from being a provider, you're looking into what best you can do for your patients, looking in deep with the insurances. Lately, I came out of most of my network participation because of the oral medicine being a fine line between the medical and the dental. Not it was like looked into the depths for the coverages, though it is medical necessity. Somehow it's like pushed under medical, but there are something that's like truly dental based. For example, the cone beam CTs that we take, and then like the silometries. We don't even have a code for silometry in the medical, and it's not even covered. So there are significant gaps in the processes. So as part of the AOIM, we are taking into account the oral medicine practice management. So we are trying to generate class codes. And the good part is that the ADA is considering the oral health and systemic health connection. And this is something that is like significantly important in the coverage perspective, that we have both ends like meet somewhere and
Yes.
optimally so that we can provide the better care that the patient deserves.
Yes, well, I hope that the ADA is tuning in and they can
Uh-huh.
hear our discussions and that we can keep with this mission. And I thought it was funny to call this channel "The Mouth is Connected to the Body." Everyone's like, well, of course it is, but insurance, our education systems, where we practice, is so separated. And it's so important to have these discussions and say, well, here is the cost of separating and the
Yes,
rationale of bringing it together. It's going to be so important in providing holistic care and stopping that patient that we talked about in our previous discussion from going to 27 different clinicians to say what's wrong with me. If we communicate and we can understand, oh, I'm going to send that person to Dr. Tope because she manages that condition like every single day, where I've seen it, as you're mentioning in a previous discussion, once or twice a year.
well, I think the bottom line is if we have better care, we can reduce cost coverages because one less doctor to see and probably get the right diagnosis, especially in the oral and maxillofacial area. And if the approaches can be driven from the governance perspective on the coverages, that will be highly, highly beneficial for the patient. On an average, there was a paper that published that they spend about $6,000 to $10,000 before they get an actual care from oral medicine or orofacial pain specialists to address that. And believe it or not, based on the Medicare rate, it's about $175 for that one visit to make the appropriate diagnosis, maybe at the most two visits.
Oh my gosh. I hope that your explanation of those insurances really help patients trying to navigate this complex avenue of dental and medical insurance. And since I know we're all patients in some way or another, I hope it helped all who are turning in today.
That
So
sounds good. And of course, we are territorial for sure because we are good in our zone, I would say, whether it's a neurologist, rheumatologist, anyone, we are good in our own areas. But I think we need some level of cross communication and cross functional leadership in order to bringing this into more effective coverages. And thank you, Jillian.
yeah, absolutely. And I was just thinking when, a really great model to consider is that model when we are taking patients with head and neck cancer. It's a
Of
multi-system,
course.
integrated disciplines because we know is so important. We have the oral oncologist, oral medicine is another term for a lot of the times the people who go into oral oncology, and the head and neck surgeon, the radiation oncologist, the speech language pathologist, the dietitian. It's like if we could all just have that model for everything,
Exactly.
be so.
Tumor board example.
Tumor board is a great example. Yeah. So thank you so much. A lot to chew on, a lot to consider as we depart today. And I hope you come on again because it's been a delightful conversation.
It's such a pleasure to be with you. Thank you so much. Thank you so much for the opportunity.